Welcome to the Mental Health Professionals Network's webinar on supporting a young woman struggling with bulimia and depression. I'm joined tonight by an esteemed panel who I'll introduce to you. My name's Dr. Mary Emilius and I'm a GP in Cairns. I'd like to introduce Jan Orman to you. Dr. Jan Orman's a Sydney GP with a long-standing interest in mental health, especially in mood and eating disorders. She has extensive experience in caring for eating disorders patients in general practice. Jan works as a GP in a university health service, as a psychological medicine practitioner in private practice, and for the Black Dog Institute as a facilitator in their education program and as their GP services consultant. She has a master's in psychological medicine and a diploma in shared care psychiatry. Jan is past president of the Australian Society for Psychological Medicine. Welcome, Jan.
Thanks, Mary. Nice to be here.
Thanks, Jan. And Dr. Warren Ward is a psychiatrist. He's been the Secretary of the Australian and New Zealand Academy for Eating Disorders since 2009. He's the Director of the Eating Disorder Service at the Royal Brisbane and Women's Hospital. Dr. Warren Ward graduated in medicine at the University of Queensland in 1987 and became a Fellow of the Royal Australian New Zealand College of Psychiatrists in 1995, later serving as a member of the Fellowships Board for the RANZCP and as Chair of their Committee for Training. He obtained a graduate certificate in management through Queensland Health from QUT in 2001. In his current position as Director of the Royal Brisbane and Women's Hospital Eating Disorders Service, he provides leadership of the Queensland Eating Disorder Outreach Service, which provides statewide education, training, consultation liaison, tertiary assessment and treatment services, and advice on statewide planning and service development for patients with eating disorders. He's also Chair of the Eating Disorders Advisory Group in Queensland Health. Dr. Ward regularly provides education and training in the area of eating disorders to physicians, general practitioners, psychiatrists, mental health clinicians, carers and others. He has published several articles in the area of eating disorders with special interest in models of service. He's a member of the Academy for Eating Disorders. Welcome, Warren.
Thanks, Mary. Welcome, everybody.
And Dr. Susan Harsh is an accredited practicing dietitian and she has completed her PhD examining the evidence base underlying the nutritional management of eating disorders. She has published widely on this topic and was awarded second place for the Peter Beaumont Young Investigator Award in 2008, the Dietitians Association of Australia Emerging Researcher Award for 2009, and the Joan Woodhill Prize for Excellence in Research Doctoral Award 2011. Dr. Hart is on the Executive Committee of the Australian-New Zealand Academy of Eating Disorders and on the editorial board of the Journal of Eating Disorders. She has 15 years of clinical experience working with eating disorders in the inpatient and day patient setting and is currently Program Manager of Derwent House, the Royal Prince Alfred Hospital's Eating Disorder Day Program in Sydney. She's continuing her research in the nutritional issues affecting eating disorder patients with a special interest in glucose metabolism and the nature of disordered fluid intake in eating disorder patients, and developing and evaluating specialist interventions for young people with type 1 diabetes and an eating disorder. Welcome, Susan.
Thanks, Mary.
So I think you can see from that welcome to all our participants from all over Australia and I believe some from overseas as well. We have a very esteemed panel of experts tonight and I just wanted to reassure the participants that I am a rural GP. Well, currently I work in Cairns. I can't claim that's rural. I specialise in working with young people. I work at Headspace and have done for about 5 years. But prior to that, I was a rural general practitioner on the Atherton Tablelands. So I'll make sure that we also think about support for practitioners who work in places without all the experts. Just to go over the learning objectives for tonight, you've all had the case study of Meredith in advance. And what we're hoping to achieve tonight is that we'll be better equipped to recognise the key principles of intervention and the roles of different disciplines in treating, managing and supporting people with bulimia and depression, and better understand the merits, challenges and opportunities in providing collaborative care to people with bulimia and depression. So for those of you who haven't participated in one of the national webinars before, a particular welcome. Just to let you know how things go, each of our panellists will be invited to present a small discipline-specific response to the case study, after which the panel will have their interdisciplinary case discussion. So they have some questions for each other. You're welcome to submit questions in the chat box that you have. And I've also been provided with all the questions that you raised when you registered for the webinar. So what we'll try to do is include as many of those questions as we can, and I'll try to keep an eye on what's happening in the chat box as well. Please be aware that it is just not possible in the time frame to answer everybody's questions specifically. So what we'll try and do is make it as inclusive as possible and really practical. The good thing about the MHPN webinars is that we try to make it practical and useful so you can go away tomorrow and use what you learned tonight. So first of all, I'd like to invite Jan to present her response to meeting Meredith. Thanks, Jan.
Thanks, Mary. I just wondered what everybody's response to Meredith was when they read the case. I wondered if perhaps they thought that this wasn't a typical eating disorders presentation, but I have to say that in terms of patients with bulimia nervosa, Meredith is reasonably typical. She's older than anorexic patients. She's had a life. Her history of bulimia nervosa, her history of disordered eating, is not from her teens, but from her early 20s. And she's presenting with depression rather than with her eating disorder. Not that that is not what anorexic patients do, but it's fairly typical for GPs to see patients. The research says 3 times more often. No, that's not right. 3 times in the 2 years prior to their diagnosis with things other than symptoms related to their eating disorder or things that are not recognised as symptoms of their eating disorder. So the GP is the first port of call for most patients with eating disorders, and most patients with eating disorders don't present with their eating disorder. Meredith presented with depression. There are a number of things listed on these slides that are typical of presentations for patients with bulimia, particularly fatigue, sleep disturbance, abdominal pain due to gastroesophageal reflux or the effects of inadequate diet or laxative abuse. Requests for help with weight loss are quite common in bulimic patients, and menstrual disturbance, as Meredith has given you a history of having. It's important to note that the history of disturbed eating may not be volunteered in that initial presentation, and GPs need to be aware of the possibility of it and actually ask specific questions looking for it. In terms of the GP assessment of Meredith specifically, it's important that at the top of that list is whether or not she's at risk of suicide or self-harm. She's got a history of recurrent depression. She's had self-harming episodes in the past. We don't know enough about Meredith to know what her risk of harm actually is. We need to know how depressed she is, whether antidepressants are an appropriate choice of treatment for Meredith, and what kind of depression she has, because that'll make a difference to whether antidepressants are appropriate or not. We need to know her history and her family's history, and we need to know what other psychiatric diagnoses exist, particularly in relation to making a comprehensive formulation that will be helpful for her future management and the communication with the rest of the team that are looking after her. We also need to know whether there's actually anything physically wrong with Meredith. She went to India, she got a diarrhea in India. Does she have any ongoing problems with her gut, or is there in fact some kind of underlying problem like celiac disease? Does she have any problems with her thyroid function? There are a whole lot of investigations that need to be done to ensure that there's no physical underlying problem. Importantly, probably immediately after, is she at risk of suicide, is there the question of whether she's in physical danger as a result of her behaviour. For example, does she have electrolyte disturbance? So you can see that there's a strong need for physical investigation. We need to have an understanding of the relationship between her depression and her disordered eating in terms of what came first in order to plan her treatment and how much support she will need to recover. The other big question is she working in the right job for that? But that's a bit further down the line. Meredith is very complex, and she's not the sort of patient that is going to respond well to very short-term care, the kind of care that's available in 10 sessions with a psychologist. So, priorities for a patient like Meredith: risk assessment, current psychological health, assessment of the presence of underlying illness, the assessment of her current medical stability, her current nutritional status, and the development of a comprehensive treatment plan. Now, your regular GP's got about 20 minutes to do all that in. So you can see that what really needs to be done in this consultation is Meredith needs to be fully engaged with the practitioner and her safety assessed. As a minimum, that is all you can do in a first general practice consultation. The rest needs to be done at future consultations. So in terms of plan, there needs to be some agreement with Meredith on clear weight and behavioural goals. She may be reluctant to give up her desire to be a lower weight. She may even be reluctant to give up her purging behaviour. All of this can be addressed by the dietitian that you're going to refer her to. And she also needs to be referred to a psychiatrist in a situation where you may be uncertain about the psychiatric diagnosis or not confident about treating the complex psychiatric issues involved. Now, I know that many GPs have extra skills in this area, and many GPs have no support. So these things they will need to do themselves. A psychologist is appropriate for attention to the bulimia in terms of CBT, the laxative abuse, the depression and the emotional vulnerability, and the career issues, to name a few. From an ongoing care perspective, as a GP, one needs to weigh her, monitor her electrolytes because of the risk of electrolyte disturbance from both the vomiting and the laxative abuse, and monitor her cardiovascular status. Longer-term complications that need to be attended to include the dental complications and the risk of osteopenia and osteoporosis and the nutritional deficits. And it's the GP's responsibility, I think, to establish a mechanism for communication in the treatment team. One of the really big problems for patients with eating disorders is that they disappear between the cracks of the various practitioners' areas of interest, and so it becomes a much more difficult condition to treat the longer it goes on. And you might note the last point. I think it's really important to advise patients with eating disorders that in order to get optimal care, it may be worth them getting some health insurance in the long term. The situation in New South Wales, at least, and I think in Australia generally, is that public inpatient care and indeed outpatient care for eating disorders is suboptimal. So there are some pitfalls for GPs. Trying to do too much at the first consultation. Don't confuse purging anorexia with bulimia. Don't take the illness less seriously just because the patient is in the normal weight range. They may be subject to fewer medical complications, but it's still a serious psychiatric illness. Don't treat the eating disorder without treating the other psychiatric problems. Always monitor their physical condition and don't try to do it on your own. You need some support, even if that's over the phone, because you're a long way from face-to-face support. These sorts of patients need long-term ongoing care, and you need to be in a position to be able to provide that. So engagement and assessment are the most important things. Sorry, I've moved on to Susan's slides. And the awareness that this is a chronic illness and needs ongoing care.
Thanks, Jan. There was probably quite a few questions that came out of that and some answers as well. I was interested in your comment about that she's very likely to need complex and ongoing care that's probably more than can be achieved with 10 sessions with the psychologist, which is what's available under Medicare. Mm-hmm. And I know that that's an issue that was raised by some of the participants when they registered. So we will probably come back to that in the panel discussion. Okay. And is it possible to give us a 10-word answer to the difference, how one would tell a difference between a purging anorexia and bulimia?
I think the simplest way is that a purging anorexic is underweight.
Okay. Thank you. I would like now to invite Susan to respond to meeting Meredith as a dietitian. Thanks, Susan.
Thanks, Mary. Thanks, Jan, for that really good introduction. Now, my slides are not coming up.
There you are.
My computer, are they?
Yeah, it's there.
Okay, it's just my computer that's not doing it. That's all right, I've got it printed out. So, Mary, I just might need you to flick the slides for me.
I'm happy to do that.
Okay, great.
So you're on your first slide.
You know, Meredith is a really complex patient, and if she presented to me, the dietitian, without other health professionals, I would be very hesitant to take her on. Like, at a minimum, she would have to be seeing the GP. But I think because of her comorbidity, there's a lot going on, and I think as a dietitian, I might really want to talk about the food, but she might want to talk about her depression. And I think, really, even though it's obvious to be talking about, engagement and assessment, and doing that really thoroughly, and I'm sure everyone agrees with that, but I think this idea of goal setting, Meredith might be used to people telling her that she has some problems with different sort of things, and my first question is, well, what is the problem for her? What are the things that she wants help with? And some of the most people are quite unsure about what a dietitian would do and how we might help them. And I think certainly for nutritional intervention, I think it's really important if Meredith is so depressed that if she's coming and talking about her risk, and her self-harm, and that really becomes a therapy interfering behaviour for dealing with the food issue. So I would have that discussion, with Meredith and set that up from the start that I wouldn't be able to talk. And I think trying to really stay focused on the food and the food goals and so on. So, and I think I've just put about consent to communicate, and I think it's that's an obvious thing, and Jan might be the referrer, but I think it's really good to have a discussion about that as well. So in terms of my treatment plan, I think I would be setting the scene and really establishing the relationships. And this question of who weighs is an important one, because it is important to weigh her, but we don't want to have 3 clinicians weighing her really frequently, because that can be confusing and anxiety-provoking. So if Jan was weighing her, I would be really happy for Jan to communicate that with me rather than weighing her a second time as part of the intervention. So the sorts of things I would do with her is really kind of start simple, and I think I've tried to summarise a lot of the different points that I would do, and I tend to get people to think really simply, and I just say, look, let's just try and get you eating a bit regularly. 3 meals, the rule of 3 is 3 meals, 3 snacks, 3 hours apart. Some people come in, they go, I want my meal plan, I want it now, I feel really confident. Other people, you talk about a meal plan and they're just absolutely terrified. So I'd kind of just be focused on some really simple things. It's not so important what you're eating, just that you're getting some structure into your eating, and really work with that. Some of the things that are very important that would be, I think, typical of the bulimic patient is she might say, well, I eat quite a lot, but when you break it down, she's full of the things like, diet foods and low-calorie foods and large, plates of salad and a whole range of things that kind of physically fill her up but are not nourishing her at all. So we'd be doing some education. She's very likely to drink large amounts of fluid and Diet Coke, and I would be suspecting black coffee and a whole range of things to suppress appetite. So I'd really be starting gently and really get her to kind of set the scene and, be setting her own goals, what she needs to do next. I guess the thing also is, as Jan sort of talked about, really putting some boundaries on weight loss. If she's losing weight, week after week, I would be sort of putting back to her that the intervention is probably not working and we need to look at something a bit more intensive. Some of the education topics, which is the next slide, but it's not coming up. There it is. Now, I would introduce these not in the order that they're written, but as the questions came up. And I think that, again, I would let Meredith kind of ask the question. She's likely to have lots of fears. But these are the things that would very typically come up. Issues around weight, and if I eat normally, I'm going to put on what, would be the first things that would kind of dominate the session. So I'd really let her ask the question. But I think that I might spend weeks and weeks and weeks. Like as Jan has said, you're not going to get too much done in the first session, and it's to go at a pace that she is comfortable with. I think some of the other education topics that I would be looking at, if it's coming through the next one, again, these are some of the other things that would come up about food and mood, and that people who are restricting will also get quite depressed, and sometimes when they start to eat quite regularly, their mood will improve. But some people have quite a profound depression. It's not going to make any difference, and I would be certainly relying on my colleagues to advise me on that. The other topics about bone health, some of the nutrition interventions there, helping perhaps with the purging, and then this idea of the 4E's rule. I mean, we haven't said that Meredith does a lot of exercise, but just really giving her the message that, if she's doing some regular moving and exercise, she would need to be eating. And a lot of clients say, well, I don't exercise, but they walk 4 hours a day to and from work and are burning up a lot of energy. So most patients would have some level of compulsive exercise and so on. So, yes, I think that's the end of my slides.
Thanks very much, Susan. I think that was an interesting comment there at the end about exercise, and that was something that was raised by some of the participants as well, is that, how do we approach that? So I guess we might park that question and come back to it as well. Now I'd like to invite Warren to present how he would think about Meredith from a psychiatrist perspective. Thanks, Warren.
Thanks, Mary. I'd agree with the comments made by Jan that this is a fairly difficult case. A recent study done by Philippa Hayes looked at eating disorders in the community and have shown that they've doubled in the last 10 years. And the most typical patient is a woman in her 30s or 40s who's binging and purging and of normal weight and is not seeking treatment. And they often have depression. So she's pretty typical. And as our previous speakers have said, we really have to look at medical, nutritional and psychological goals altogether. So an interdisciplinary approach where there's good communication is really important. And coming from Queensland, I just feel the need to state that not all public services are suboptimal. In Queensland, there's quite good public outpatient inpatient services, and it does vary a lot around the country. So it's about finding the best treatment for your patient. So I really just want to go through 3 assessment goals for me as a psychiatrist specialising in eating disorders, and 5 treatment goals to leave plenty of time for questions. In terms of assessment, as well as engaging the patient and finding out what's brought them here, which is very important, I'd want to clarify that they actually do have an eating disorder, and if they do, which one they have, and hopefully help them to see that they have one too, because often there's a bit of denial. Secondly, look at the medical complications and risks so that they're managed. And thirdly, look at psychiatric comorbidities, the most common one and relevant in this case being depression, and having those treated. So in terms of clarifying the eating disorders diagnosis, there can be a lot of causes of low weight, a lot of medical causes, malabsorption syndromes, malignancies. There can be a lot of psychiatric causes, depression, alcohol abuse. But body image disturbance is really pathognomic for an eating disorder. In other words, it's only in eating disorders you get the severe dissatisfaction and disturbance of body image and the fear of gaining weight, which our patient does seem to have. You also get weight loss, which she's had. Even though she's had normal weight, she's had a lot of weight loss, and I would say she's suffering from significant malnutrition with her diet. Severe dietary restriction is the biggest risk factor for eating disorders. So most eating disorders, the best understanding of the cause of eating disorders is that they're caused by severe dietary restriction, leading to changes in the brain so that the person becomes extremely obsessive and they can't get out of that thinking. And of course, we live in a culture where dieting and weight loss is encouraged, which can trigger this brain syndrome. And some people are more at risk. Those people with obsessional, perfectionistic, conscientious personalities, which is a somewhat inherited trait, are more at risk. And then we really get the secondary effects of dietary restriction, whether the person has bulimia or anorexia, which is binging, which is a normal response to restriction, purging, which, as I would explain to patients, is a normal response to binging, and then you get the exercise and laxatives. So treatment, just jumping ahead a little bit, whatever the eating disorder, involves what Susan was saying, which is getting the eating back to regular, adequate eating. That actually helps mental functioning as well as their medical functioning. And amenorrhea is important as a symptom. Very important often for the patient who says, but I've always been a low weight and so has my family. They'll say, when was your last period? If it was 3 years ago, you can talk about the risks of osteoporosis and that it's not really normal and or healthy. Medical complications, I think it's important for all members of the team to be aware of those. Jan's covered them very well, but the things I'd be looking for in my 5-minute medical assessment would be, I usually ask them, have you had any fainting? And then the cardinal cardiac symptoms, any chest pain, palpitations, shortness of breath, or ankle swelling. And then I would want a blood test looking at whether their potassium's low or their phosphate low, because both can lead to sudden cardiac arrest, and whether their glucose is low, because that can lead to sudden death as well. The best predictors of whether someone with an eating disorder is at high risk of dying imminently are bradycardia and hypertension. So if their heart rate's 40 or less, or their blood pressure is 90 or less, less than 90, they're at risk, and the College of Psychiatrists recommends admission for such patients. Other things we'd look for are neutropenia. So this is low levels of white cells to fight infection. We invariably see this with patients with malnutrition, which corrects on nutrition. These are useful educational things too for the patient who says, I feel fine, there's not a problem. And of course, osteoporosis and crush fractures is a concern if someone's having abnormal amenorrhea for several years. I'd also want to look at psychiatric comorbidities after I've looked at the medical complications, especially in this case depression. The easiest way to diagnose depression is to ask someone in the last 2 weeks if they felt depressed most of the time or not been able to enjoy anything. That's pretty well your classic screening question for depression, and as Jan said, assess the suicide risk. I'd always be looking for OCD, obsessive compulsive disorder, other anxiety disorders, personality disorder, and alcohol and substance use. In terms of treatment, it can get very complex. Often these patients are sometimes a bit obsessional and get focused on the detail. That's actually a symptom of the starved brain. So I always encourage my staff to try and look at the big picture and look at what are the 5 goals. And with this and every other patient, the key goals would be to engage, inform, and educate the patient. For example, educate them that laxatives don't help you lose weight. They just get rid of stuff you're not going to digest anyway. That they can cause the bowel to die and end up with a colostomy, which often is not an outcome they want. Osteoporosis, I tell them about all the patients I've got with crush fractures at the age of 19, which makes weight loss look a bit less attractive. And then medical stabilisation, as I've mentioned, not only monitoring them carefully at least weekly and admitting them if need be, but also with refeeding syndrome, which I can talk about if we have time. But basically, as they're being refed, it's important to monitor their phosphate especially, because they can be at risk of cardiac arrest if the phosphate drops. Treating comorbidity, studies show repeatedly that if you treat someone with low weight or malnutrition with antidepressants, the antidepressants don't work. And so depression is a common symptom of malnutrition, and nutrition is the best treatment. And so I'd be talking to my helpful dietitian about that. But sometimes you could try antidepressants, but I should say they don't work because they're half as effective when you're low weight. Nutritional restoration and rehabilitation is the cornerstone of treatment, and I think, in this case, the GP dietitian and myself would all be working together on that. And I explained to the patient the nutrition is to get that nutrition to your brain so that you can starting to improve your mood and having your thinking more clearly of the big picture rather than obsessing over calories, weight, and diet. And it allows the antidepressants to work. And once that's done, then the psychotherapy, which it can be 6 to 12 months of CBT or another psychotherapy, is more likely to work. So it's stabilise medically, restore weight, and then psychotherapy in that order. Often patients want it in a different order, but it doesn't usually work. Also for bulimia nervosa, fluoxetine, usually at higher doses of up to 80 milligrams, is shown to be effective in randomised controlled trials. Not as effective as CBTE, but I'd offer the patients either or both. With the fluoxetine, you do need to start at 20 and go up slowly by 20 milligrams every 2 weeks. Thanks, Mary.
Thanks, Warren. I just got a bit confused there. I understood that you were saying that antidepressants are not so effective for depression, but you are also saying that you might often use fluoxetine.
Sorry, I was being confusing. Antidepressants, fluoxetine, not all antidepressants, only fluoxetine has been shown to be helpful for bulimia nervosa in reducing the obsessions and the compulsions and the binging. But if someone is very underweight, say below a BMI of 18.5, studies show they're only half as effective. So for this patient, hopefully it would be effective, but it'd be more effective if she's having regular nutrition, because the fluoxetine needs some serotonin nutritionally to work on.
Sure. So in the very underweight patients, we need the treatment for their depression is nutrition.
Correct. And actually for the patient with normal weight like her who's lost 30 kilograms and is only eating 1 meal at night, that's also true to some extent. You can have malnutrition, depression, all those things at normal and high weights. And
there was also some questions from the participants. By the way, may I say that we have over 250 participants logged in, so that's great. And just a housekeeping matter, because we started 10 minutes late, we are going to finish 10 minutes later as well. So we'll be logging off at 8:10 daylight savings time, or 7:10 if you're in sunny Queensland. Warren, would you be able to comment just briefly on the specific brain changes that you see in the starvation syndrome?
Yes. We know about the brain changes because of a study done in the 1950s by a physiologist called Ansel Keys, Keys. If anybody wants to Google it, it's on Wikipedia. He got 36 men who were psychologically and physically healthy and starved them over a 3-month period. The reason he did this was there were a lot of people coming out of prisoner of war camps, and he and his team wanted to know the physiological and psychological effects of starvation and refeeding. To cut a long story short, these men were starved for 3 months down to BMIs of 15 or 19 to lose 25% of their body weight, observed for 6 months, and then refed. What they found was 100% of these healthy men had profound psychological changes, the most prominent one being that they went from what I would call big picture thinking to very detailed, obsessive, finicky, nitpicky thinking, and especially focusing on food. And they would have rituals associated with the food where they'd want to eat their food slowly over 2 hours. They'd become depressed, moody, withdrawn. 3 were admitted to psychiatric hospitals. 1 chopped 3 of his fingers off in a suicide attempt. 3 became suicidal. And all the changes that we actually see in people with anorexia with very low weights admitted to our units, and they were restored to normal on refeeding. And we see that typically with all our patients too, that once they get the regular nutrition, especially with anorexia, low weight, but also with bulimia, their thinking improves. They get their sense of humour back, the ability to think flexibly returns. These are not changes that would pick up on normal cognitive tests, but there are some neuropsychologists who have been working in this area that show that really is that switch from the detailed thinking to the big picture thinking.
Thanks for that, Warren. It's an interesting issue. I read in a journal the other day that some of the studies that have given us the most useful information in medicine and probably in mental health would never get through ethics these days. Exactly. It is a really interesting sort of philosophical question. Now, we're going to have move into the part of our evening where the panellists discuss the case with each other. And I'd like to invite Susan, first of all, if you'd like to address one of your questions to Jan.
Sure. So, as a dietitian, I think with the complexity, and I would be so reliant on my colleagues, so I would really be wanting to talk to Jan a lot about, if there's low potassium and what's going on. And, I would sort of definitely be relying on Jan's advice to direct that. So I think, in terms of a collaborative relationship, it would be sort of to touch base with Jan and say, well, look, how do we communicate? Do we email? Do we text? How do we do it so we can stay on the same page with this client? And I think that often that's just really, really hard to do. So that would be my first question for Jan, is around her medical risks and the purging. And I agree. I think because she's not eating and she's got the laxatives and the vomiting, she's, particular risk of low potassium. But the other thing I've found in some of my research is patients engage in a behaviour we started calling flushing. So what they do when they're vomiting is they'll drink lots of water and then continue to vomit. And so I'd be really curious, not just that she vomits, but what does vomiting mean to her? Because people do different things. Anyway, I'm off the track, but that's my question to Jan about really relying on her for the medical stability side of things.
Okay, the question is kind of about how often I monitor and how I communicate the results of that monitoring to you. Is that...
Yes. Thanks, Jan.
Yeah, that's okay. Meredith, I'd be seeing at least fortnightly. And more often if she looked like she was becoming unstable. And at those fortnightly visits, I'd be monitoring her electrolytes, her potassium, her phosphate. I'd be weighing her and taking her blood pressure, checking for a postural drop in her blood pressure, checking her pulse. And maybe even, I wouldn't be doing an ECG fortnightly, but if there was any problem with any of the other cardiovascular indicators, then I'd certainly be doing an ECG as well.
Sorry to interrupt, Jan. So even though her BMI is actually 22, you would still do fortnightly blood tests?
Yes, I would, because she's vomiting so often. Once she reduced the frequency of her vomiting, then I might reduce the frequency of the medical monitoring. But certainly, and also don't forget the laxatives. The laxatives are a real problem as far as electrolyte imbalance is concerned. So maybe for the first month or 6 weeks we do fortnightly monitoring, and if things settle down and the regularity of her vomiting decreased and her laxative abuse started to get better, then we'd negotiate some other frequency of visits. But in order to communicate that to Susan, there is a specialist that I work with who calls me the SMS Queen. I SMS everybody in the team, the weights, and if there is anything that I am concerned about medically, I will SMS everybody in the team with that information as well. I certainly don't use email, because using email with patient information is contrary to privacy legislation in New South Wales at least, and probably all over Australia. You mustn't put identified patient information in an email that's unencrypted.
Although you can send it through a fax to an office of
you can send
not knowing who's going to pull it out of the fax.
And I understand the irony of your smile. I think probably talking to someone on the telephone is the best way to do it, but that's not always easy when people are as busy as we are. So I think that phone first, SMS second, SMS alert to ring me up. That's another way of doing it. And the other thing I do is I make sure I copy the results of the blood tests to the other members of the team. When I do the blood test, the pathologist is happy to send the results elsewhere if I request it. So they're the ways I can keep communicating. Did that answer the question, or have I answered my own question?
No, that was great, Jan. You did answer Susan's question. And then I wondered if you would like to ask Susan a question.
Susan, one of the questions I had to ask you was, do you think this patient would be suitable for a day program sort of situation? What are there situations where a patient like Meredith might be appropriate in a day program?
I think she would potentially, definitely for a day program, but I think, that's where we would all have to work together, because I just would want to know just how stable her mood and her self-harm was. Mm-hmm. And one of the questions I'd be really curious about is, she says that she did in adolescence, and why did it stop? So if she said to me, well, it stopped because I started restricting, or I developed my eating disorder, I would have a lot of concern about how she'd go in a day program, because once her eating became stable, there's a danger that her self-harm would flare up. So, I mean, it's hard to tell from the information that she has, because if she's got profound depression and she doesn't have much control over her self-harm and has not got particularly good emotional regulation skills, that might mean she's not so suitable for the day program. Mm-hmm. So I think we'd all have to do our assessments and Warren do the assessment and then come together and decide would we put her in and put all that information. I don't think I could make that decision on my own. I think the three of us together could kind of get that plan. I certainly wouldn't feel confident just to do it unilaterally. So that would be my answer, more information. Yeah. And she may well, I mean, certainly, Jan, as you've said, this is a fairly typical patient for us. The majority of our patients will have comorbid, depression, some level of self-harm. If you ask enough, most eating disorder patients would have self-harmed at some point, and why they may not necessarily cut or burn, they often have a range of risk-taking behaviours which we would want to be talking to them about. So she's a fairly, I'd say, typical patient for our program.
And sometimes that the eating disorder itself is a form of self-harm.
Definitely.
Especially for bulimic patients. I think they're often very messy underneath the eating disorder. Sorry about the technical terms.
I think we like technical terms, Jen. That's probably how we all think. Susan, following on from what you were just talking about, then you had some questions for Warren about managing that risk, but also how, as a dietitian, let's say you were running a day program and Meredith was participating and you became concerned that there was an increase in risk of self-harm, how would you wanted to ask Warren about what you would do or how you would access support?
Yeah, that's right. I think that it's really important to have the backup plan, and I think the way the services are, if she has, her eating disorder becomes more stable, she's eating more, she might put on some weight, and I suspect that the binging and vomiting is an emotional regulation strategy. So once that gets a bit more stable, I would expect her to become dysregulated. So I think that we don't want to kind of not have a plan and then it happens and then we're having a crisis. I think it would be very important to set that plan up at the very start, and the patient is a part of that. So, there might be a conversation sometimes this happens, and if this happens, we would liaise with your psychiatrist, and we might need to think about an inpatient admission, or we might need to think about stepping out of the program. So I think being really transparent right from before the patient's even admitted is very, very important, and to investigate possibilities and make sure that there is a backup plan, because the last thing you want is to say, well, you can't come to our program because you're too depressed, but you're not going to get any other treatment, and that's obviously very unhelpful.
So I think that one of your questions was whether you could ring Warren if you had further concerns. Warren?
Yeah, so first thing would be assessing risk and then setting up a risk management plan for her self-harm or suicidality. And she is potentially at risk because depression is a risk factor for suicide. Eating disorders are too. With anorexia nervosa, but also there's up to a 20% mortality rate, with half of those deaths being due to suicide. In bulimia nervosa, there's a significant suicide risk as well. So I would be asking her, have you had any thoughts of ending your life, of suicide, which is different to self-harm. A lot of people self-harm as a way to help them deal with difficult affects like scratching and so forth. That's not with suicide intent. So I want to know if she's actually listening. And the key thing I'd be saying, clarifying, do you have any intent to end your life? She may not, but I said, I would say in future, if you had thoughts where you were feeling very hopeless and wanted to end your life, who would you call? So I'd first ask her what her plan is, and she might say, I'd call my husband, or I'd call you, or I'd call my GP. So as long as she's got a plan where 24 hours a day she could call somebody, that would be the key to preventing her suicide risk, I think. And that plan could be done by GP, psychologist, psychiatrist, whichever mental health clinician is seeing her. If she's got underlying depression, that obviously needs to be treated because that is a reversible risk factor for suicide. Could you call me? Absolutely. I think you've raised a good point where we all need to be clear on how we like to communicate with each other, the three of us and the team, and what times we're available. For example, I'm available in business hours. I explain this to my patients. and I give them the number of my public psychiatric emergency centre that's available 24 hours a day, where the clinician would actually have their files on computer and could respond. And I give them that on a card so they know the number to call if they were unsafe.
Thanks, Warren. There's been a lot of comments in the chat room about the fact that we have no psychologist on the panel. And
yes.
It is a really interesting point. And I would have thought, and I'm sure it is true, that most of the patients that you work with in multidisciplinary teams in specialist centres also have a psychologist. So I wonder if I can just raise that with the panel in general and have your comments on that.
Maybe. Could I speak to that first? Yeah, I noticed that too. And I guess my comments, and I think one of the questions is, when you see a patient with an eating disorder, who needs to be in the team that you set up if you're the first clinician to treat them? And for me, they need three things. They need medical monitoring, they need nutritional restoration, and they need psychological input, someone to help them with their behaviour and thoughts. Now, sometimes you might have one clinician who's a very experienced GP who works in that area, who could do all of that, medical monitoring, nutritional support, and
Dan looks like she's shaking her head.
I'm nodding my head because I don't think any GP is capable of doing all those things.
Probably not. Or a psychiatrist, for example, I would feel sort of half confident doing most of that, and the psychological input. In some cases, more typically, I think you'd have a GP monitoring the medical side of things, a dietitian looking after the nutritional side, and a psychologist or other psychotherapist doing the CBT. That would be your sort of...
And Warren, how important, I mean, one of the things that seems to have come through in all of your presentations is that, and in the questions from the participants, is about therapeutic alliance and engagement. So one of the things that would seem to me most important is having the people on the team that the patient was willing to work with as well. So perhaps Jan's nodding. Do you want to respond to that one?
Yeah, it's no good sending a patient to somebody that they don't like or they find confrontational. Unfortunately, if there's only one person in that professional group that's available to you, that's a problem. You might end up having to do that kind of work yourself. However less skilled you are at it than perhaps the dietitian or the psychologist that you'd like to refer to. But establishing that therapeutic alliance is so important because these patients are people who are ashamed of their illness and who really don't want to get better. The anorexic patients don't want to get better, and often the bulimic patients don't want to get better if that means they're going to gain weight.
Okay. And for people who are in towns where perhaps there is only one practitioner and the patient doesn't like them, or they have social anxiety and won't go anywhere, are there any online resources that, well, A, can clinicians access for resources, and B, can patients access for support?
Well, I think if you're in that position, you are obligated to upskill yourself, and I'd like to recommend the Centre for Eating and Dieting Disorders online education program that has been up and running. It comes out of Sydney. That's where the Centre for Eating and Dieting Disorders is, and if you look at that website, that's a terrific education program that gives you a great deal of knowledge about how to manage patients with eating disorders. So if you're a GP or a psychologist in the town where there are no other professionals, it's really mandatory that you have that level of knowledge at least. As far as online resources are concerned, there are some support websites. There are a whole lot of deleterious websites that eating disorders patients can get onto as well. The Pro-Anna website should be avoided at all costs. But there's also an iPhone app called, what's it called? Recovery Record, which is a good cognitive behavioural tool to manage the dietary aspects of the eating disorders via your own mobile phone. So I'd recommend having a look at that because that can be a helpful thing to use.
Yeah, that's been relatively new, and I think it's was developed by someone at the University of Wollongong, but I don't know the full history, but it's been, I think, my knowledge, very well received by clinicians and by patients. And we actually, even in an intensive program, particularly when there's gaps, like with Christmas, we actually really encourage people to use the Recovery Record app. And we've heard nothing but praise for it, actually. So, yeah.
So we might get those resources from Jan and Susan and Warren, if you have any as well, and we'll put them on the website so people can access them afterwards as part of the podcast. Warren, are there any resources you wanted to mention?
Oh, just briefly, the NEDC, National Eating Disorder Collaboration. If you just Google NEDC, there's some great resources there for people suffering from eating disorders, for family members and for clinicians. That's a great resource.
Specifically for binge eating disorders, there's Christopher Fairbrooks' book called Overcoming Binge Eating. I think that's what it's called. Can I have some support on that?
Absolutely.
That's CBT and nutritional advice around binge eating and recovery in it. I have successfully used that with a patient as a self-help recovery book. She's and simply seen her from time to time to give her some support in using that book. So
that would take a fairly motivated and
relatively intelligent person to do that. And but there are some people who, with support, can do that. And it's a good book for practitioners to read to know what they should be doing with patients.
And Warren, I know you have an association with the Eating Disorders Outreach Service, and I know that not all our participants are in Queensland, but can you just briefly mention that for those who are?
Yes, the Eating Disorder Outreach Service provides a service mainly for clinicians throughout Queensland from whatever discipline to provide advice, intake, do assessments for your patients, and training. We train over 2,000 people a year as well. So
I've just found that really useful as a GP, and your resources are really good.
And you can be contacted through the Royal Brisbane Hospital. I can give you the number, but 31140809.
One of the things I found valuable, Warren, was it had for GPs, it had a list of what BMIs you should be worried about and what potassium level and what phosphate level, and like a clinical checklist. Because if you don't do this all the time, it's hard to remember all of it. So those one-page checklists are great.
They're called their access pathways, and they're available for GPs, and we're happy to provide them nationally if people want them.
Thank you.
I'd also just like to endorse what Jan said about the Overcoming Binge Eating by Christopher Fairburn. Many patients, including the ones like Meredith, do want to get better, but they don't know how, and a book like that can help them. And when I was a junior clinician reading that book, I really got how to treat bulimia after reading that book. It really helps with that.
The other thing to read is anything by Janet Treasure.
Okay. Now, we've had this, because we're trying to collaborate, and some of us are in different sized towns and some of us are working in private practice or public practice. Susan, I know that I understand that you're working in public sector, but you probably have colleagues who work as a private dietitian. Do you have any reflections or any thoughts on how the Medicare system, is there enough, or is it useful to access dietitians through the enhanced primary care system where the patient can access 5 sessions per year?
Yeah, I think like with the psychology, it's just not enough or helpful, and I think the other thing is that those 5 sessions are shared with all your allied health professionals. So if you want to see a physio, it's 4 dietitians, 1 physio. So it's certain. I mean, I don't do private practice now, but there's significant out-of-pocket costs for patients. Who they say, I really want to see you, and they're going to need to see me more than 5 times so it really isn't adequate. And I think that's, in my mind, that's one of the biggest barriers to getting, like the ideal team would have clinical psychologists and other people involved. But I think it's just, some people are able to afford to go private, and unfortunately a lot of the clients that we see here at our public service, they, are not able to see that, and the public services don't provide all the clinicians that are necessary. So I think it's a big problem.
And a question for everybody, given that we've got those limitations on people like dietitians, but also for psychologists and social workers, OTs, on the mental health plan, we've got 10 sessions now of focused psychological strategies. is it, I just wonder if that's all you've got, is it appropriate to do your best with the 10 sessions, or are there situations in which it would actually be harmful and you'd be better off not doing anything?
I'd like to make some comments about that. I think the important thing in that first assessment, if you see a patient, is to get them back for the second session. And the typical patient, in my experience, thinks that they're stupid, this is all their fault, very embarrassing, and there's no effective treatments. And, but someone's convinced them to come along to see you. So I think the key messages I want to get to the person in the first session is, it's really good that you've come to seek help, because this is an illness that you didn't choose to have, that it can easily develop if you go on a severe diet, and there are evidence-based effective treatments available. And it is a serious illness, and if you don't get treatment, the consequences can be... So you want to highlight the seriousness, but instill some hope, realistic hope. And I educate the patient, say the evidence-based treatments for this are guided self-help, which is what Jan was talking about. So there's really good data to support guided self-help with a book such as Overcoming Binge Eating by Fairbairn, 55%, 60% cure rates with bulimia with that. Same with fluoxetine at higher doses. And the treatment with the most effectiveness is CBTE, with about 80 to 90%. But CBTE is a highly specialised treatment that requires a lot of training, usually the psychologist. But there are, I guess, those three treatments. The depression is very treatable. So I think even if there might be only 4 or 5 appointments available with dietitian and psychologist, I would encourage them to go along and see someone who knows what they're doing, who can do some of these evidence-based treatments, because then they find that, oh, well, if I can find some money or resources or even a public service, I can go and continue this treatment. But a lot of people get general counselling which doesn't work. So I don't think general counselling or general psychotherapy, I've seen people have that for 10 years, it doesn't help the bulimia. Bulimia responds to really specific treatments like CBT, where there's a strong behavioural focus in getting normal eating happening. So I'd really want to explain that to them and inspire them to go and get some effective treatment.
I mean, I think Jan mentioned earlier that one of the things that she would do is have a discussion about private health insurance, and I think, very early on in treatment is really just kind of having an open discussion about, things that other patients have found helpful, and, one of them is to get private health insurance, potentially, and you sort of kind of educate some clients, and some of the things that we do with our financially disadvantaged patients and not working is to kind of do budgeting with them, to look, is this something that they can afford? Is it going to be helpful looking at pros and cons? And generally, particularly patients with bulimia, are probably spending a lot of money on binge eating and laxatives, and they may actually be stealing as well, because it's the only way that they can afford it. And we found that a really helpful strategy, just to look at, the support and the budgeting. Can we help you? Because it's not sort of the first thing to think about with treatment, but can be very, very helpful in getting them to access the services that they need.
Thank you. Now, there's been some interesting questions coming through regarding the theme of trauma. There was a particular question that I really wanted to raise. So someone has said that they're finding young girls, 14 to 16-year-olds, so this is not quite Meredith's demographic, but who have things like an eating disorder and depression and suicidal ideation, anxiety, and some self-injurious behaviours, not so severe, not life-threatening at this stage. And they are increasingly evident, so they're quite complex presentations and quite common. And this person's working within a trauma-informed care approach, but they often are dismayed to see these patients come back from other services with access to diagnosis of quote-unquote emerging personality disorder as a secondary diagnosis when someone's only 14 or 15. So I guess that's something for Warren to comment on, if you don't mind.
People with eating disorders seem to fall into two groups. First group is the group of the very conscientious, perfectionistic, high-achieving person who often doesn't have a history of trauma, but they have a very obsessional personality style, and they go on a diet and often get that restricting form of anorexia. The second group are the group who've had some problems with their attachment in early life, and that can include abuse and trauma. And they discover that a person with that sort of history will have a lot of negative emotional states which they need to find ways to manage. And starving, binging, purging and exercising, as well as drinking, cutting and drugging, are all really effective ways to help to deal with unmanageable emotions. So in that second group with the trauma, the eating disorder behaviours are their solution, their survival and coping strategies, and that needs to be respected, I think. So what I would say to such patients is, the trauma you've experienced has caused you to have lots of unbearable emotions. Sounds like starving, binging, purging are working well for you, and they sort of give a bit of a wry nod. Say, would you be interested in learning any other strategies to help you with those difficult affects? Because they're causing a few problems, those strategies. And that's where there's great treatments like DBT, dialectical behaviour therapy, which actually teach people to learn other coping skills to deal with trauma. I think I have no problem with the comment emerging personality disturbance, because a personality disorder is a disorder where a person's, by definition, way of viewing themselves or others is becoming problematic, and trauma is a very common cause of personality disturbance. For me, it's all just different language. But the way I'd explain it to the patient and see it myself is that they're having trouble regulating emotions, and they need help with that. And there are specific therapies that help with that. And all the eating disorder treatments or psychological treatments are involved in helping people with that as well.
Jan's lost her phone connection, so we're just waiting for her to dial back in. I have a question for Warren and Susan, since you can hear me, about OTs. So someone has said, does anybody work with OTs? And if so, what role do they play? Susan?
Yes, we have our OT is a fundamental part of our team, and she is amazing. I think I'm so lucky to have her. And in terms of the disciplines that actively deliver treatment every day, it's the clinical psychology, the dietitian and the OT. And our OT is very multi-skilled. So what she does, an CBT exercise intervention once a fortnight. She does art therapy once a fortnight. And she's absolutely fantastic doing the practical and social eating component of our program. She does cooking with the patients, and the group that we do have another dietitian who actually they do once a week an outing or cooking, and it's actually the most popular part of our program. So whoever the OT is like, our OT is fantastic.
And I think there will also be teams that have mental health nurses in them. Warren, you'd be working with nurses?
Yeah, we work with mental health nurses, OTs, social workers, psychologists, dietitians and medical staff.
And I've had a team that had an exercise physiologist in it.
Yep, absolutely.
It would be great, yeah. I think, it's interesting in service development. I think that teams come together in a number of different ways. And it can be, like for us, it was, that was the services at the hospital that we set up. So I think teams can look different in terms of their disciplines, but there's that, the shared role, which is an eating disorder therapist, and it's multidisciplinary. And we certainly know that multidisciplinary care is, I guess it's the best standard that we want, but it might look different in terms of what are those specific disciplines, but you've got a range of people in, and I think the more the better, but sometimes it just depends on what resources are around.
Thank you. And once we're approaching our last 10 minutes, and I just had a question that's also really important about how we can best involve families and carers. So I'm not sure, maybe Jan, we haven't heard from you for a little while, so how would you go about involving other people in Meredith's life in her support?
In Meredith's life, Meredith being 26 and claiming to be completely without support, that may indeed be difficult. And in fact, I'd be a bit worried about involving Meredith's family on the grounds that there seem to be some underlying significant issues in Meredith's history that suggest that she has perhaps some personality issues or some ongoing, certainly some issues with recurrent depression anyway. So I'd be a bit wary about involving family members. But with Meredith's permission, I would be happy to talk to members of her family that she felt would be supportive, or friends that might be supportive. And I would only talk to those people with Meredith in the room. I wouldn't be having any private consultations with other members of her family or her friendship group. So I'm particularly in helping to identify when Meredith's mood is going down, and to let people know that what to look for in terms of danger, suicidality, for example, and that's an issue, particularly if she can't communicate that to people herself.
Susan or Warren, do you want to talk about how you might involve families, perhaps not in Meredith's situation, but just in general?
Yeah, we would involve families as the default setting always. I agree with this case, you may not, but the reason we do that is, again, for anorexia nervosa, the most effective treatment for anorexia nervosa is family-based treatment, in particular Maudsley family therapy, where the family are supported in refeeding their child. But also, I think there's been an unfortunate tradition of blaming families for eating disorders, which is not really warranted. But we find that engaging the family to work with the healthy part of the person on a regular basis is a really important part of effective treatment. We find if we don't do that, the family often gets very anxious and interferes anyway. I'd recommend the book by Janet Treasure, who Jan Orman recommended earlier. Janet Treasure's written a fantastic book called Skills-Based Training for Caring for a Loved One with an Eating Disorder. It's written by Janet and a carer, and it actually has really good advice and tips on parents, spouses, on how you can help your loved one. But a really good thing to do, I think, with the patient with eating disorder and the family, if they're in the room, is to say, tell your mum how she can help you.
Susan, with the dietitian aspect, how do you involve families?
So, look, I think it's really important. I think, as Jan Orman has said, that I would tend to always try and have the carer and the patient in the room at the same time. Sometimes I find between sessions I get phone calls from carers and they go, I've got to tell you something, don't tell my daughter that I rang. And so on. And I would just sort of kind of say, look, I think it's unhelpful. I'm really happy to, meet with, and I think doing the best that I can to kind of support the carer and get them into treatment and set up some boundaries around that. I think that most people, it doesn't matter what age they are, they can't do it on their own. So I think to engage what social supports or family supports they have with the eating, and particularly, with the dinners and suppers, one of the things that we say is that it's going to be hard for you to do this on your own. Like, if you can get someone to at least sit with you at dinner and for an hour after the meal, I think it's going to be much more helpful.
One of the things I like to suggest is that the person doing the caring for the eating disorders patient goes and talks to somebody themselves, not the same people that the eating disorders patient is talking to, though. I think that's of great benefit. Where I work at the university, I often see young people who are seeing me because they're looking after someone themselves, not necessarily with an eating disorder, but one of their friends who's got depression, and they really need help themselves in dealing with that. So support for the carer from another source is a really important thing.
And I just would like to mention there the Mental Illness Fellowship of Australia. I really have only had experience with them in North Queensland, but they're an Australia-wide organisation, and that's their brief, is to support families and carers. And they have a good website, and then it links you to local support groups, and they have individual clinicians. It's really good.
And in relation to eating disorders, the Butterfly Foundation does a lot of that as well.
Right. Thank you. Now, we have a few minutes left, and I'd like to invite each of you to just give us your take-home messages. I think we'll start with Susan.
Gosh, take-home message. I can't think of anything else.
Look, I could have given you some...
Very unlike me. I think the most important thing is like the multidisciplinary team. I think that it's very hard work, whether you're, private practice or in a public service. But it's to really use your colleagues, use your GP. I think it's tremendously difficult to be the sole therapist managing a patient with an eating disorder, even if it's like not for clinical management, but just checking in, because I think there's often, I find like after a session, you're like, oh, did I do the right thing? And that support and mentoring is so important for providing good clinical care. I think for rural areas, it's really challenging, but I do quite a lot of, Warren can probably speak to this a little bit more than me, but I do phone support and a range of different things for clinicians who I can't do face-to-face support with.
So you might actually have a virtual multidisciplinary team and one or two people on the ground.
Sort of directly seeing the patient, but it's just really like the mentoring and supervision and talking through the case is just so important.
Warren. Thank you, Susan.
Yeah, I've mentioned most of my take-home messages, but just one other one I'd like to mention is remember, patients with eating disorders are ambivalent. There's two parts to them, as it were. There's the healthy part that really wants to get rid of the eating disorder and have a normal life, and when their friends call them and say, hey, you want to come over for dinner? They're able to say, yeah, that'll be lovely. And then there's the eating disorder that all it cares about is numbers, weight, shape. It's relentless, it's punitive, it's mean, it's nasty. It helps them. And so whenever you're talking to a patient, I think acknowledge both parts. So if they say, look, I'm fine now, I don't need any more help, I'd say something like, it sounds like you're feeling confident, but from what you've told me, you've had this for a year, and maybe it's good to just keep seeing someone for a few months to make sure you're okay. And if they say, I'm not coming here anymore, all your food is disgusting, I don't want to put on weight, and I'd say it sounds like the eating disorder is terrified of the numbers. But I remember from our previous conversation, you said you wanted to be able to get back on track and to be able to have a bit more of a normal life. So just to try and, it's actually a therapeutic strategy that's often used, is separating the illness from the person. And that can be helpful when you're engaging a person, and to encourage the family to see it that way as well. So that was all I had. Thanks.
Thanks, Warren. And Jan?
Okay, I think it's important to remember that this is a chronic psychiatric illness with potentially severe medical consequences. So you need to be aware of both those arms of the disorder and the treatment while you're looking after patients with eating disorders. But I remember maybe a decade ago, maybe more, I said to one of my patients when I first started talking to health professionals about eating disorders, what should I say to them? What's the most important thing that I should say to them? And she said, remember, we are not just our eating disorder. And I think that's very important in treatment. And in fact, I can almost shift the message, I think, to we are not our eating disorder. And so to remember that this is a person with a range of interests, a range of needs, a range of with a life, hopefully, who simply has an eating disorder that is not all of them, and in fact, probably not part of them either.
Thank you very much. Well, thanks to the three of you for a really interesting discussion. Jan has reminded us that we're also in for the long haul for these complex patients when we provide support for them from any discipline. Meredith reminded us right at the beginning about, Susan reminded us about working with Meredith's goals. So as well as the goals we have as clinicians, helping the patient to identify what's important to them, because if they feel they're getting something out of it, that helps them to engage and keep coming. And Warren spoke to us about making sure we clarify the diagnosis, and I guess one of the key medical things for me there was that those cardinal signs about slow heart rate or bradycardia and low blood pressure, hypotension, signify that people basically need an urgent medical admission to hospital, and that's something that we need to remember. So thanks very much to all our participants tonight. I'm sorry for the clunky start, and thanks to the panel for managing that well, and apologies again to those of you who've typed questions in the chat box which we haven't had time to answer. Please make sure that you complete the exit survey before you log out. So you can click on the Resources Library tab at the bottom of your screen, and then you will get sent your certificates of attendance in about 4 or 5 weeks. You are welcome to continue talking to each other in the chat box, and in a couple of days every participant will be sent a link to the online resources that were discussed tonight. If you're interested in finding out more about mental health professionals networks around Australia and their online activities for next year, please visit www.mhpn.org.au. Thanks again, everybody, and have a great evening. Good night.
Thanks, Mary.
Right.